So, rheumatoid arthritis, what comes to mind first? When you say rheumatoid arthritis, what first comes to your mind about this entity, rheumatoid arthritis? Anybody? What do you picture when that word is uttered? These words are uttered, rheumatoid arthritis. What comes to mind usually is that it's a joint problem. So it's a joint disease, arthritis, of course. So rheumatoid arthritis. Toid always means it's similar to, right? So, like for example, uh, typhus and typhoid. So typhus is what is caused by rickettsia. Typhoid is something that resembles typhus. So typhus fever and typhoid fever, like that. So rheumatoid arthritis means there must be rheumatic arthritis. Rheumatic arthritis is what we've already discussed, is part of rheumatic fever. So rheumatoid arthritis and rheumatic fever. Likewise, so it's a joint problem, sort of resembling rheumatic arthritis or rheumatic fever, but certainly a lot of differences. Plenty of differences between rheumatoid arthritis and rheumatic fever. So this is a joint problem basically, but is it restricted to the joints? No, it's a systemic joint or systemic inflammatory disease. So we can't always think of rheumatoid arthritis as an isolated joint disorder. It has definitely extra-articular or outside of the joint manifestations. So we need to watch out for those. Those with extra-articular manifestations generally have a very more severe form of the disease. So rheumatoid arthritis patients who have extra-articular manifestations generally tend to have a more severe disease. So, but the hallmark is joint involvement, and that too usually the the smaller joints predominate over the larger joints. So it's a small joint issue. Unlike, let's say, osteoarthritis, even in osteoarthritis, it's a joint disease, but the large joints predominate over the small joints. But rheumatoid arthritis, the other way around, small joints, there is large joint involvement, but much more involvement of the small joints than the large joints. Correct? So whenever you come across a patient who has joint pains, one of the differentials you will start out with is rheumatoid arthritis. Then from there, you'll try and eliminate or try and rule in whether the patient does or does not have rheumatoid arthritis. So as I said, rheumatoid arthritis is a chronic inflammatory disease that predominantly affects the joint, but it has a multi-system involvement. So the inflammation or the process of inflammatory pathogenesis that starts out in the joint will spill over into the into the systemic circulation. That means systemic involvement does occur to some extent in all patients of rheumatoid arthritis. So it can't be considered as a pure joint disease, like for example osteoarthritis. That's why osteoarthritis is not considered as a inflammatory arthritis. Osteoarthritis, although the name itself has osteoarthritis, although it has arthritis in it, it's not considered an inflammatory arthritis, mainly because the inflammation is there. In osteoarthritis also, there is some amount of inflammation, but it's only restricted to the joint. It doesn't spill over into the rest of the body. So that is why a lot of patients with osteoarthritis will also continue taking steroids, or they'll find relief when they take NSAIDs. Over the counter, they'll go take steroid tablets or they'll take NSAIDs and they will find relief. That's because there is an inflammatory element that is restricted to the joint. Whereas in rheumatoid arthritis, it spills over into the rest of the body. So there will be at least one additional manifestation along with the joint involvement. Definitely, females are affected more often than males. If males develop rheumatoid arthritis, generally their disease will be more severe. So when males have it, males who do develop rheumatoid arthritis, they have a severe disease. Okay, and certain manifestations, like for example, ILD. So RA-ILD, it's called rheumatoid arthritis interstitial lung disease, is more common in men who develop rheumatoid arthritis. So although rheumatoid arthritis by itself is rare in men, if by chance a man were to develop rheumatoid arthritis, generally the disease would be more severe in them, and the manifestation of RA-ILD tends to occur more often in men with rheumatoid arthritis than women. Okay, and it's like a mother's disease. So that's how sort of I remember it. Actually, my mother has rheumatoid arthritis. So, and she developed it around when she was in her 40s. So that's how, like, I remember that it is something that affects people who are in their 40s, and more often affects women. Okay, so it's a disease that affects mothers. So definitely not a younger age group. So for example, if it was a young person who presents with multiple small joint pains, so finger pain, finger joint pains, that means the metacarpophalangeal, the interphalangeal joints, the wrist joint, these pains are there, and it should not be acute. So if it is acute, you should always think of either current infection or post infectious. That means either generalized viral polyarthritis or arthralgia, polyarthralgia or arthritis versus post-viral. Post-viral. Usually it'll be a viral. Viral diseases, viral infections generally produce diffuse joint involvement, whereas bacterial will generally produce septic arthritis. That means a particular focus, particular joint will get infected. So if it is an acute joint polyarticular manifestation, you'll either suspect an acute infection or a post-infectious sequelae. For example, chikungunya. So when you say post-viral, we generally denote the most common example is chikungunya. Chikungunya cases are on the rise here in Bangalore. So chikungunya, I'm sorry, got the spelling wrong. Chikungunya. So you can suspect if it's an acute polyarthritis versus arthralgia, you can suspect this. Whereas if it is a more longer standing, so chronic, more chronic, subacute to chronic, you will start differentiating between the other causes of uh, joint inflammation, joint manifestation, inflammatory polyarthritis. So in that, one of the differentials, if the person is a lady, you will think of disorders such as rheumatoid arthritis, or you will think of SLE. Okay, I'm just noting these two for now. There are other differentials, but if you are thinking between these two, what will help? SLE generally it will be a younger lady, younger girl. Okay, younger age lady developing slightly long-standing joint involvement with multiple joints being affected, especially the small joints. You'll think of lupus. Whereas rheumatoid arthritis, it will be slightly older. So between the third to fourth, so 30s, 40s, sometimes even 50s, third to fourth decade. Okay, that's when they get involved in rheumatoid arthritis. There are other differences, of course. Rheumatoid arthritis is an erosive arthritis. It will erode into the joints. So the synovial space will progressively reduce. The synovial cartilage will get eroded. So this is a feature of rheumatoid arthritis. It's an erosive arthritis. SLE, in contrast, is not an erosive arthritis. In SLE, the synovial cartilage is preserved. So generally deformities are much more in rheumatoid arthritis because it's an erosive arthritis. SLE also, they can have deformities, but it's not an erosive arthritis. The deformities will not be so bad. Okay, so onset is generally the fourth or fifth decade, sometimes even in the sixth decade. A number of factors are important for pathogenesis of rheumatoid arthritis. Genetic predisposition is also important. HLA-DR4 I've not mentioned, but also HLA-DR1. So HLA-DR1 and HLA-DR4. If a person has these HLAs, and in them there is a certain trigger, the trigger could be in the form of an infection. The trigger could be in the form of a medication, a drug. So something that has led to triggering of the immune system. So the immune system is triggered. Basically, what happens is there is a change. What happens? There are certain peptides. These peptides could be okay. So these peptides could be in the form of collagen 2, or they could be in the form of vimentin. These are found in the joints. Okay, these are composed. These peptides are composition of the joint structures. So these might get altered. The structure gets altered. So due to the insult, maybe it was a drug, maybe it was an infection, maybe it was smoking. So anything like that. So a particular trigger. There is a trigger like infection, certain drugs. You guys know Kaplan syndrome, no? Kaplan syndrome is associated with, that is yet another trigger. Smoking. Kaplan syndrome is associated with, we've discussed this in respiratory. So obviously Kaplan syndrome involves rheumatoid arthritis, but what else is important in Kaplan syndrome? It is the exposure to silica, right? Silica. So coal workers pneumonia, even the coal workers pneumonia, the coal dust will have some amount of some content of silica. So uh, let me put it as the either coal workers pneumonia or silica exposure. So silica, coal workers pneumonia, some trigger. What will that trigger do? It will produce an alteration in peptides, certain peptides like these, like sometimes even IgG, the immunoglobulins. Okay, so there is some trigger that will lead to citrulination. So what it will do is it will convert the arginine present in these peptides into citrulline. So citrulination of these peptides are mediated by certain triggers. Okay, for some reason this change happens. It basically happens because they have this HLA predisposition. And so these peptides, which are present in the joint, mainly in the joint, but outside the joint also sometimes, these will get altered. And once they are altered, they will become self antigens. They'll start inciting inflammation. So citrullinated peptides will start leading to increased inflammation. Inflammation in the form of cell mediated, as well as both T cells get activated and B cells get activated. So B cells will produce antibodies against these new antigens, new autoantigens or new self antigens, these citrullinated peptides. So finally, what you will get? You will get a lot of immune complexes. So many autoantibodies are getting produced and going and attaching to their respective autoantigens and therefore producing immune complexes, as well as there is going to be T cell mediated destruction of tissues. So the T cells will now migrate to the site of these altered antigens. There they will start activating macrophages. They will start producing cytokines like interleukin 6, like TNF alpha. So they are responsible for generation of all the destructive cytokines, okay, as well as activation of macrophages. So all this will lead to destruction, local destruction of the tissues. And the immunoglobulins produced by the B cells will generally be IgM type, and they will end up causing deposition of immune complexes. Okay, so I'll write it as the ICs, immune complexes. So these all together will contribute to the disease ultimately. Ultimately, rheumatoid arthritis manifestations are because of cell-mediated cytotoxic T cell. So CD8 cytotoxic T cells will go and start invading all the tissues which have the altered peptides, like for example, vimentin and collagen 2, as well as it will start activating macrophages. It will start destroying, because these are present in the joint, they will start destroying the joint, reduce the synovial space, it will destroy the synovial cartilage. Likewise, the immune complexes will also go and deposit there, and that will also continue to further incite inflammation. It will cause activation of further activation of complements. So all these immune complexes, they will activate complements, complement mediated destruction, cell mediated, and cytokine mediated destruction. So you can get an idea of from where we get certain of these autoantibodies, which we actually use for screening and diagnosis of rheumatoid arthritis. So the IgM that is directed against the immunoglobulin, we already have an immunoglobulin, but we end up, because it gets the structure slightly changes, this the change of arginine to citrulline. It's all that's happening because of whatever the trigger was. That leads to IgG, the immunoglobulin itself, IgG class of immunoglobulin being recognized as an autoantigen. So the body mounts an autoantibody response against it. So you guys are not answering. Please tell me, what is this known as? The IgM, which is directed against one's own IgG. What is it known as? The IgM directed against self IgG is known as, you guys know this? Okay, it's known as rheumatoid factor, RA factor, rheumatoid arthritis factor, or rheumatoid factor. This is nothing but an IgM that is directed against one's own IgG. Why is it getting directed? Because there's a slight change in composition. So this change in composition may not just be this citrullination. It may be other types of changes in composition of the immunoglobulin. So rheumatoid factor is not very specific to rheumatoid arthritis. Rheumatoid factor may be produced in other diseases also. For example, in infective endocarditis. So if you remember the minor criteria for infective endocarditis, one of the minor criteria is immunological phenomena. In immunological phenomena, you get, I told you the way to remember it, Roger. So rot spots, Osler's nodes, glomerulonephritis, and rheumatoid factor. So you can get rheumatoid factor even if the person doesn't have rheumatoid arthritis, because rheumatoid factor is just an IgM that is directed against IgG. Most often IgM. It may be another class of immunoglobulin also. It may be IgG also. But then what we test for, we generally test for rheumatoid factor. No, when we ask for a rheumatoid factor test, the lab assay will generally specifically test for IgM. Okay, so this is rheumatoid factor is not specific to rheumatoid arthritis. Yes, it's seen. It's especially going to be seen in more severe disease because this is not just in the joint. Immunoglobulins are outside the joint. So if there's going to be a high concentration of RA factor, the higher the RA factor concentration, it is indicative of a more severe disease. That's because it is involving immunoglobulin outside of the joint. Okay. That brings us to what is the more specific autoantibody that is seen in rheumatoid arthritis. So if we think of rheumatoid arthritis as a combined cell-mediated and immune complex mediated disease, so which means type 3 plus type 4 type of hypersensitivity. So it is a type of hypersensitivity, type 3 plus type 4. So if you think of which antibodies you can see in rheumatoid arthritis, one is RA factor, IgM directed against IgG. The other is the more specific one. So most specific autoantibody in rheumatoid arthritis, if you are asked, is something that is directed against citrullinated peptides, which are present within the joints. Collagen 2, vimentin, these are within the joints, citrullinated peptide. So if you're strongly suspecting rheumatoid arthritis, the one antibody you want to see as positive in your tests is anti-cyclic citrullinated peptide. Okay, anti-cyclic citrullinated peptide. So if you're getting this as positive, that means it is a very specific, highest specificity, higher than rheumatoid factor. Very specific autoantibody in rheumatoid arthritis. Okay. Clear? So this is in brief about what's happening, why is happening. The more the stronger the stimulus for immune response. So for the inflammation, the stronger the trigger and stronger the stimulus for the inflammatory response, the more severe the disease. The more severe the disease, the more the RA factor, and certain manifestations will occur only in severe disease. For example, vasculitis. Rheumatoid arthritis can cause vasculitis. So that is a manifestation that's seen only in very severe disease. Okay. Clear? Right. So it is a chronic disease. It's not going to start suddenly. So tomorrow, if you see a patient who has come with small joint pains, if it's a 40-year-old lady who's come with small joint pains only since 3 days, 4 days, don't straight away suspect rheumatoid arthritis. It's unlikely. Dig deeper, probe a little more and ask, is it only since 4 days or has it been there for some time, maybe 4 months or 6 months, and only now it's increased? That's why you have come to the hospital. Is it like that? So you probe a little. If she's sure till 4 days back, she was absolutely fine. It's there now. It started only 4 days back. Then don't entertain the diagnosis of rheumatoid arthritis straight away. Suspect other things like infections or an acute flare-up of basically an infectious disorder only. So either a systemic infection, or rarely you can get as side effects of certain drugs, like for example interferon. So interferon, when it is given, it can produce this kind of flu-like symptoms, which includes polyarthralgia. So otherwise, it is an insidious onset. Fatigue, anorexia, weakness, and vague musculoskeletal symptoms may be present. at the onset. There is something called very early rheumatoid arthritis also. So there are entities like early rheumatoid arthritis, very early onset rheumatoid arthritis. Okay, early onset rheumatoid arthritis, very early onset rheumatoid arthritis also, but usually it has insidious onset. Acute onset with the development of polyarthritis and constitutional symptoms is not so common, but uh, palindromic onset, where recurrent acute episodes of joint pain and stiffness can occur, lasting only for few hours and days. This is a unique manifestation, not very common. So they can have something called palindromic onset, where there is a very acute episode characterized by joint pain and stiffness, lasting only for a few hours to days. Okay, so otherwise it's mainly acute, mainly insidious. I'm sorry, mainly insidious. In fact, this is reflected in the criteria. So in the criteria for diagnosis of rheumatoid arthritis, the minimum duration that you expect a patient to have joint pains before making a diagnosis of rheumatoid arthritis is 6 weeks. Okay, 6 weeks is an important time period in rheumatoid arthritis, both for diagnosis and for treatment. When you start them on DMARDs, disease modifying anti-rheumatoid drugs, you don't expect the benefits up till at least 6 weeks. So only beyond 6 weeks, DMARDs will start producing their effects, reducing the joint manifestations. Okay, so articular manifestations. Remember, rheumatoid arthritis is going to affect predominantly small joints and going to be symmetrical. It is going to be erosive, and certain joints are affected more than the others, and certain joints are totally spared. Okay, so joint involvement is usually symmetric. It will be in insidious onset. So this kind of a picture, let's say in a 40 to 50-year-old lady, then you can definitely suspect rheumatoid arthritis. Then go ahead for further evaluation. Okay, they will have manifestations like pain, swelling, tenderness, and stiffness, joint stiffness. So this is a very useful history. Anytime that the person complains of joint stiffness, it means there is inflammation in that joint. Okay, so if you get that history that there is joint stiffness, early morning stiffness especially, it's called morning stiffness, which lasts for at least 1 hour. So this is a characteristic feature of any inflammatory arthritis, typically rheumatoid arthritis also. Okay, and the most common joints which are affected are the wrist and the finger joints, that is the metacarpophalangeal and the proximal interphalangeal joints, along with the wrist, knees, and in the lower limbs, the metatarsophalangeal joints and the proximal interphalangeal joints of the toes. Now, this is a very important point. Basically, we mean to say in the hands, the DIP is spared. Distal interphalangeal joint is spared. So if you come across a lady in her 40s, 50s having arthritis that has affected the hands, and it's involved the distal interphalangeal joints, one of the differentials you should consider is psoriasis. Straight away, you should rule out rheumatoid arthritis. I mean, DIP involvement in rheumatoid arthritis is very, very uncommon, very, very unexpected. If it is there, significant DIP involvement, distal interphalangeal joint involvement, is not a feature of rheumatoid arthritis. Instead, you should entertain a diagnosis of psoriatic arthritis. I'm sorry, psoriatic arthritis. Psoriatic arthritis can affect patients who don't have psoriasis yet. That means if you look for psoriatic skin lesions, it may not yet be there, but the joint is inflamed, especially the DIP. And you may have to work a little harder to look for the psoriatic rash. It may be in the scalp. A lot of times, the psoriatic lesions are present in the scaly, silvery scaly lesions. They're present in the scalp. Okay, so you may have to look extra hard for locating these skin lesions. Okay, or look at the nails. Nails may have pitting or onycholysis. That may give you a clue, even though they don't have a skin manifestation. So look in the scalp, look in the hair, look in the nails also. If they don't have obvious scaly, silvery scaly lesions in the skin itself. Okay, so what happens because of DIP involvement in psoriasis is they have something called as sausage fingers. Sausage fingers. So sausage fingers means involvement of not just the PIP but also the DIP. So there is a diffuse thickening of the digits, and because there is DIP involvement, there is on X-ray there is there is a manifestation known as pencil in cup. Pencil in cup deformity, which is seen in psoriatic arthritis because of DIP involvement. Okay, this is in contrast to rheumatoid arthritis where the DIP is spared, but the PIP will be inflamed, and even proximal to that also there will be inflammation. So this is known as spindling, spindle-shaped finger. So spindle-shaped or spindling of the fingers. This is what you see in rheumatoid arthritis. Okay, because of sparing of distal DIP is spared, distal interphalangeal joint is spared. So this is a very, very important clue. If it is an older individual, man or woman, usually male, if it's an older person who has DIP involvement, then it is more likely to be osteoarthritis. Okay, middle-aged lady presenting with DIP involvement, think of psoriatic arthritis rather. Okay. Then again, there are other joints which are usually spared. So spondyloarthritis is not a common manifestation of rheumatoid arthritis. Okay, so DIP is spared and intervertebral joints are spared, except one intervertebral joint can get involved, but usually intervertebral joints spared. Okay, except the atlantoaxial joints. Okay, atlantoaxial joint is the only spine joint which can get involved in rheumatoid arthritis. Otherwise, if they complain of low back pain, no, don't think of rheumatoid arthritis. In fact, exclude it. Straight away exclude it. You don't see it. Not in rheumatoid arthritis. Okay, so yeah, so this is what I was saying, spindling of the fingers. This is not what you see in psoriatic arthritis. You see sausage digits in psoriatic arthritis. Dactylitis, no? It's called dactylitis in psoriatic arthritis. Anyway, hyperextension. So what happens is it's an erosive arthritis, right? Because it's an erosive arthritis, there's going to be a destruction of the joint space, and finally the tendons may just slip because the surface to which they are attaching, it's getting eroded away. The tendons they're attaching to the bone surface, it's getting eroded away. So finally, it may come to a point where the tendon slips, and when it slips, it will produce deformities, and that's why you can get certain typical deformities in rheumatoid arthritis, which is one of them is swan neck deformity like this. So the distal interphalangeal joint would be flexed, the proximal would be hyperextended. So PIP hyperextension, DIP flexion. So this kind of a deformity is known as swan neck deformity. So I told you DIP doesn't get involved, but here it's just a matter of the tendon slipping. That's all. Tendon subluxating rather. So because of subluxation of the tendon, this kind of a DIP deformity occurs, but it's actually not involved. The joint itself is spared. Okay, the other way around, if there is flexion in the PIP and extension, hyperextension at the DIP, it produces Bottineur's deformity. So Bottineur's deformity is also because as a result of subluxation of the tendon due to erosive arthritis, gradually reducing the surface area for attachment of the tendon. Bottineer means buttonhole deformity. It's called buttonhole deformity. Okay, and then there can be other changes like hyperextension of the first interphalangeal joint with flexion of the metacarpophalangeal joint. So this loss of pinch can occur, but this is known as Z deformity. So Z deformity would be where there is extension in the interphalangeal joint, the interphalangeal joint of the thumb with flexion at the metacarpophalangeal joint. Okay, so this kind of a deformity is called Z deformity. If you see, the shape will be Z shaped. Okay, that can occur. Yeah, it's here actually. So Z deformity is radial deviation of the wrist with ulnar deviation. This is okay. Palmar subluxation of the proximal fingers results in Z deformity. So usually it affects the thumb. That is what produces Z deformity. Ulnar deviation is also very important. Ulnar deviation of the digits can occur. Okay, ulnar deviation. Then there's something called dropped finger, where there is extensor tendon rupture, which can end up producing something known as dropped finger. Right. Otherwise, carpal tunnel syndrome, because of all the inflammation around the tendons. It's actually in the joint. The joint inflammation can spill over and can spill over into the carpal tunnel and produce compression of the tendon, compression of the nerves, like the median nerve, producing carpal tunnel syndrome. And then the whole hand may be swollen in very acute cases with pitting edema and dorsum, giving rise to boxing glove appearance. This and all okay. It's more like a textbook description. But then early stages. So nowadays it's not so common to come across very gross deformities. Patients of rheumatoid arthritis with gross deformities because of improved methods of diagnosis and early medical attention being sought by patients. Patient education has improved, so you don't see florid deformities so much like before, because they're on treatment, because disease modifying agents are started quite early, so which is good. Uh, it should be like that. Yeah. So this is the spindling of the fingers. Okay. If it was sausage digits, you would have involved the distal interphalangeal joint also, but here it's paired. It's only involving the proximal interphalangeal joint. This is rheumatoid arthritis, spindling of fingers. This is Boutonnière's deformity. There is flexion at the proximal interphalangeal joint and hyperextension at the distal interphalangeal joint. The reverse, this is swan neck deformity. Okay, quite clear. It's only subluxation of the tendons that's producing the effects. Okay, and this kind of, I didn't tell you, when there is a lot of inflammation in the synovial membrane, no, it develops into something called as pannus. Okay, pannus is the inflamed, hypertrophied mass of synovial membrane as a result of arthritis. So this pannus is what is going to cause all the destruction. Okay, so here there's a lot of joint inflammation and edema noticeable in the wrist. Wrist is also, so when you give a handshake to the patient with rheumatoid arthritis, no, they'll wince. So if you're suspecting rheumatoid arthritis, just give a handshake. So when you give a handshake itself, they'll wince, because these joints are definitely going to be involved, especially the wrist joint, the metacarpophalangeal joint, the proximal interphalangeal joints going to be involved. Okay. Long-standing rheumatoid arthritis can lead to more severe deformities. So you have to be able to distinguish these kind of deformities from the nodes of osteoarthritis. So in osteoarthritis also, you get involvement of the DIP, and they're going to be nodes. Okay, the osteophytes, they will end up producing nodes. These are known as Heberden's nodes and Bouchard's nodes. Okay, so you have to be able to differentiate. So generally, that kind of a patient would be older, and it may be a man. They won't have systemic manifestations. It will just be a joint manifestations if it is osteoarthritis. Okay, foot and ankle can lead to broadening of the forefoot. That's because of involvement of the metatarsophalangeal joints, which is common. Metatarsophalangeal and metacarpophalangeal joints, both are commonly involved. Okay, there's going to be a lateral deviation of and dorsal subluxation of toes. So this is known as windswept deformity. Okay, windswept deformity. This can be seen in the feet. Okay, and there can be a flexion of the interphalangeal joint, the first interphalangeal joint flexion with an extension at the metatarsophalangeal joints. This is known as hammer toe. Hammer toe. So there can be changes which are seen even in the feet. So hammer toe, windswept deformity, and then eversion of the hindfoot subtalar joint. Hallux valgus deformity may be seen. There's one more thing that can be seen, which is known as bunion. Okay, bunion is the prominent head of the first metatarsal. So the head of the first metatarsal may end up becoming very prominent because of the deviation of the distal bones, the phalangeal bones, and that's why this is known as bunion. Okay, so these are deformities that may be seen in the foot and the ankle. Hallux valgus also. Okay, then the other joints that are involved, it could involve. So basically, a lot of times you think of it as only a small joint disease, but large joints can get involved. But polyarticular, that means only few large joints being involved, is unusual for it to be rheumatoid arthritis. Usually it has to be multiple large joints for you to consider diagnosis of rheumatoid arthritis. Only few large joints getting involved, then not such a strong suspicion. Whereas even few small joints getting involved, you can suspect rheumatoid arthritis. Okay, that's how the joint distribution generally is in RA. Okay, so flexion contractures can occur in the involved joints, no doubt. Shoulder joints, elbow joints can get involved, though they're large joints. Elbow joints are large joints, shoulder joints are large joints, but they can get involved. It can even lead to rotator cuff fraying and rupture. So, rotator cuff fraying and rupture. Cervical spine involvement, remember it's not the atlanto-occipital, it's the atlanto-axial joint that gets involved. That's the only spinal joint that gets involved in rheumatoid arthritis. And this can unfortunately sometimes lead to compressive myelopathy. So a compressive myelopathy may result due to subluxation and will lead to quadriparesis. And it can be very dangerous because the phrenic nerve is right at that level. So if the C3, C4, C5 starts getting compressed because of the subluxation of the atlanto-axial joint, I'm sorry, then they can develop quadriparesis, even respiratory arrest. Okay, so it can lead to compressive myelopathy and quadriparesis, quadriplegia. Cricoretinoid involvement can lead to hoarseness of voice. Rarely it can lead to stridor. And Baker's cyst. So sometimes in the knee, when the knee is involved, in the knee joint, there is the synovium, right? So the synovial space is there, the synovium is there. So because it's eating away into the joint space, so if this is the bone, just for representation, okay, these are the bones which make up the joint here, okay, just for representation. Now slowly it's eroding into the bone, so it's bringing the bones together. So the cartilage is getting eroded away. So because the cartilage is going, the bones are coming very close to each other and squeezing the joint space. It may squeeze it to such an extent that this synovial membrane may sort of project outwards, project behind that too. So it will start projecting outside, posteriorly. And this is what is known as Baker's cyst. So Baker's cyst can occur in the popliteal fossa. That's because of the compression of the synovial membranes and synovial space by the already or ongoing erosions in the synovial cartilage in the knee joint. Okay, is this clear till now? Or somebody has commented something. Hold on. Why morning stiffness occurs? Okay, sorry. Basically, morning stiffness occurs as a result of inflammation. So whenever there is inflammation, what do you expect? Do you play sports? So if you look back to quick pathology revision, do you guys know what are the cardinal features of inflammation? Celsus gave us the 5 cardinal manifestations of inflammation. Excellent. Rubor means redness. Calor, which means warmth. Very good. Calor. Dolor, very good, which means pain. One more and then we have the answer to your question also. Calor, rubor, dolor. It has to swell. It has to swell up, no? So you will get a tumor. And finally, loss of function, punctulacia. Okay, spelling, you please forgive me for the spelling if it's wrong. So basically, when there is inflammation in a particular at a particular site or particular tissue, you have to stop its function. That means that particular organ or tissue should not be functioning for the inflammation to be successful. Okay, I mean that it's a result of inflammation. Anytime that there is inflammation, it is going to result in loss of function of that particular tissue. So it's, as part of punctulacia, there's going to be irritation of the surrounding muscles. Because of inflammation, it's going to cause inflammation of the surrounding muscles and irritation of the surrounding muscles and lead to muscle spasticity. So the peri-articular muscles will become spastic because they're getting irritated by the function by the inflammation. So this is basically being done to bring about a reduction in the movement usage of the joint because it's inflamed. So let the inflammation do its job, let it address the problem there, then the functions can restart. It's like that. So that's the purpose. Anyway, the mechanism of the morning stiffness is because of increased spasticity of the muscles surrounding the joint, which are getting irritated by the inflammation contained within the joint. Okay. So morning stiffness, whenever you come across, always think of inflammatory cause of arthritis. Okay. Clear? Yeah. So as I said, it's not going to stay limited to the joint. The inflammation will spill over into the rest of the body also. And therefore, there can be extra-articular manifestations. Even in mild disease, they can have extra-articular manifestations. The extra-articular manifestation may be as simple as, let's say, fatigue. So all the patient may complain about is fatigue. Okay, and that's a result of the inflammation basically. Okay, if the inflammation is slightly more severe, especially TNF alpha getting involved, then it can lead to anorexia. So they can have certain non-organ related, so constitutional manifestations of inflammation. Any inflammation will produce constitutional manifestations also. Fever. This is also constitutional. Sorry. Constitutional manifestation. Okay, so again, that is brought about by interleukin 1, interleukin 6. These are what generate fever. No? So because of the interleukins or rather cytokines spilling over into the blood, there can be constitutional manifestations, or sometimes there may be specific manifestations related to certain organs. Like, for example, anemia of chronic disease. Hepcidin, right? So hepcidin gets upregulated, and that brings about anemia of chronic disease. This is one of the most common. If you're asked what is the most common manifestation, extra-articular manifestation of rheumatoid arthritis, actually fatigue would be the best answer. But if you're asked a more specific answer, anemia. Anemia of chronic disease is the most common extra-articular manifestation of rheumatoid arthritis. If you want a slightly specific answer. Otherwise, fatigue is always going to be more common. Okay, and then there are other manifestations. Lymphadenopathy, rarely because it's going to cause T cell activation. Okay, immune activation. Basically, it is a hypersensitivity response. It's going to activate the immune system, the adaptive immune system, much more than the innate immune system. So that's why lymphadenopathy, because all the T and B cells are getting activated, lymphadenopathy is expected. But if it's much more, very intense, much more intense activation, it can lead to something called Felty syndrome. Okay, so basically, Felty syndrome is very, very, very intense activation of the immune system. So much so that the spleen will start enlarging and the neutrophil count will start coming down. It will actually end up draining the neutrophils. So neutrophils numbers start coming down. So this is Felty syndrome, an extreme end of immune hyperactivation of the immune or hyperreactive feature or hyperreactive manifestation of inflammation, immune system activation in rheumatoid arthritis. Okay, so then there can be lung involvement, which most often is characterized by pleuritis. Occasionally, parenchymal fibrosis, pleural effusions can occur. Rheumatoid nodules. These are also quite common, especially in severe disease. So severe disease, no, they can have rheumatoid nodules that will usually be attached. It'll be there on the extensor surfaces like the elbows. These nodules can get attached to the periosteum beneath, or can get attached to the bursa that lies beneath. That's how the rheumatoid nodules are. Sometimes the nodules occur elsewhere, like in lungs, which is why I was asking you what is Kaplan's syndrome. Kaplan's syndrome, they'll have rheumatoid nodules in the lungs along with the pneumoconiosis that is due to Colworker's pneumoconiosis or silica exposure. Vasculitis can occur. Again, a manifestation of severe disease. So you don't get manifestations like, I'll tell you, see. So, hold on, where did it go? You don't get manifestations. sorry, yeah. You don't get manifestations like rheumatoid nodules, vasculitis, Felty syndrome. These you don't get unless the person has severe disease. Okay, these are indicators of very severe disease. Okay. Then in the eyes, episcleritis, scleritis, keratoconjunctivitis, spillover of inflammation leading to rank ligand activation. Therefore, in turn, activation of osteoclasts will lead to osteoporosis. Pericardial effusion, the cardiac involvement, pericarditis is the most common manifestation, but it can go beyond pericardial. So there can be involvement of the valve, there can be involvement of the aorta, aortitis can occur, but most common is pericarditis. Then rarely Raynaud syndrome, carpal tunnel syndrome, peripheral neuropathy, all these can be manifestations. Okay. So briefly touching upon some of these extra-articular manifestations, rheumatoid nodules, they're quite firm, they're attached. This is what you have to remember. Prevalent in more severe disease. Okay. Subcutaneous nodules. And it need not be, these are basically granulomas. Okay. These are just granulomas. So these granulomas, if they occur in the subcutaneous tissue, they're subcutaneous nodules. If they occur in the lungs, lung granulomas, then it is rheumatoid nodules in the lungs. But it can involve not just the skin, but even the lung and the pleura. Okay, so that is rheumatoid nodules. They're attached to the periosteum, to the bursa, like that. Basically, these are granulomas, so they will go and get fixed onto the surrounding structures. Rheumatoid vasculitis, not very common, but it's not common because we see patients early. Patients come to us early, and we start them on DMARDs early. That's why you don't see severe manifestations like this so often now. But anyway, manifestations could. It's basically immune complex deposition. So if you know what is cryoglobulinemia, in cryoglobulinemia or cryoglobulin's are they are immunoglobulins which can precipitate at lower temperatures. So very often they will have an accompanying rheumatoid factor. So they will have an IgM that is directed against IgG. So that's basically what is common to them is immune complexes. So immune complex deposition will lead to vasculitic manifestations. So small vessel vasculitis, generally it will be small vessel vasculitis. And therefore the manifestations will generally involve small vessel vasculitis and will involve the skin, small vessels, no? Where are the small vessels in the skin? It's in the nerves. So if you think of causes of peripheral neuropathy, among the causes of peripheral neuropathy, vasculitis is a rare cause. But among the vasculitis causing peripheral neuropathies, rheumatoid vasculitis is the most common. Okay, overall, it's very rare, but then it is the most common vasculitic cause for neuropathy. Okay, and very rarely kidneys may get involved. So glomerulonephritis, very rare, very rare. So very small capillaries. Glomeruli are capillaries, right? They're tufts of capillaries that are housed within the Bowman's capsule. So small vessel vasculitis will involve these small vessels, skin, nerves. Very rare glomerulonephritis. This is as good as not involved. Okay. Yeah. And with regards to pleuropulmonary, so pleural, when it comes to the respiratory manifestations, pleuritis is the most common manifestation. Pleuritis, the most common manifestation. Just a second. Pleuritis is the most common manifestation. Otherwise, the lung can get involved and there can be fibrosis, especially the lower zones. So when it comes to RA-ILD, rheumatoid arthritis ILD, certain points you can remember. So sorry, RA-ILD, rheumatoid arthritis ILD. One thing you can remember, it's more common in men than women. Usually it will have a UIP pattern. UIP pattern, do you guys remember from ILD discussion? UIP, usual interstitial pneumonia. interstitial pneumonia. This pattern will be there in rheumatoid arthritis. So usually, most often autoimmune disorders or immune related disorders or connective tissue disorders which produce ILD will have a NSIP pattern. But rheumatoid arthritis is an exception. It produces a UIP pattern. Okay. Lower lobe predominant. It's part of UIP. Lower lobe predominantly being affected is lower lobes predominantly being affected is part of a UIP pattern. And then you can remember Kaplan syndrome. Kaplan syndrome is when there is going to be an association of rheumatoid nodules with silicosis or coal workers pneumonia. Okay. One more thing you should know is, there can be pleural effusion. When there is pleural effusion in rheumatoid arthritis, the level of glucose in the pleural fluid will be very low, which is surprising because that kind of a low glucose in pleural effusion you expect in disorders like infections. So infections can produce low glucose, but this is an exception. Very low pleural glucose in the pleural fluid is a feature of rheumatoid arthritis. Okay, so this kind of a pattern. So subpleural reticulation. So you can see the subpleural reticulations, which are predominant in the lower lobes. So lower lobes, subpleural reticulations. The image is not very clear on zooming. I'm sorry, but there is traction bronchiectasis and honeycombing here. So honeycombing changes, traction bronchiectasis. Okay, that little bit you should remember. What is UIP? UIP is characterized by subpleural reticulation most often in the lower lobes, and there will be traction, a lot of honeycombing, a lot of fibrosis, no? So because of fibrosis, there's going to be honeycombing, traction bronchiectasis, much lesser GGOs. So these are features of UIP. This is what you'll see on a CT. This is important practically. Why? Because one of the main DMARDs for treatment of in the treatment of rheumatoid arthritis is methotrexate. Methotrexate itself can lead to ILD, but the ILD produced by methotrexate is usually of NSIP pattern. Usually, okay, most commonly methotrexate will produce an NSIP type of pattern ILD. So that will not be that will be mainly GGOs. Okay, that will be mainly GGOs. Whereas here it's a lot of fibrosis. So if you start a patient of rheumatoid arthritis on methotrexate and many months or many years later they develop lung manifestations. Now you are confused. Is the rheumatoid arthritis producing the ILD or is the methotrexate producing the ILD? You have to stop the methotrexate. So one of the features that can help you to distinguish between the two is look out for what is the HRCT showing. HRCT thorax, if it shows a UIP pattern, then it is more likely to be rheumatoid arthritis. More likely to be UIP pattern, rheumatoid arthritis. If it's showing an NSIP pattern, then it's more likely to be methotrexate induced. In fact, multiple drugs used in rheumatoid arthritis can produce interstitial lung disease. Even TNF alpha inhibitors, for that matter, TNF alpha inhibitors, when they can end up producing ILD. Okay, so this is an important point. Lung manifestations. Okay, HRCT. If you want to confirm the diagnosis of ILD, you have to do an HRCT. In fact, that's not the gold standard. Gold standard is biopsy, but the investigation of choice for ILD is HRCT. Gold standard is biopsy, lung biopsy. Okay, lung biopsy features will also resemble NSIP radiology features only. Subpleural reticulations, a lot of fibrosis. Okay, now cardiovascular manifestations in rheumatoid arthritis. Pericarditis is the most common manifestation, most common. I'm sorry, most common. And atherosclerosis. This is a very important point. So any chronic inflammation, no, any disorder which has chronic inflammation is not good for the heart, for the blood vessels. So some common features, they'll have constitutional symptoms. Any disorder, this is common to any chronic inflammatory disorder. Constitutional symptoms will be there. Fever, weight loss, loss of appetite, anorexia will be there. Okay. Along with that, they can have anemia of chronic disease, hepcidin upregulation, anemia of chronic disease. They can have, as I said, as a result of chronic inflammation, uh, they will have an accelerated atherosclerosis. Okay. Along with that, they can have systemic amyloidosis, secondary amyloidosis. Okay, secondary amyloidosis, systemic amyloidosis. That's because any inflammation, what it will do, it will produce the AA amyloid protein. No, so this AA amyloid protein, because of chronic inflammation, the beta pleated structure will change, and that can lead to deposition, polymerization, therefore amyloid deposition. So kidneys can get affected in rheumatoid arthritis. Okay, like that. Then there are certain features like thrombocytosis. Okay, many patients with chronic inflammation will have thrombocytosis. Platelet counts generally go up as a result of chronic inflammation. So among the certain common features of any chronic inflammation, is atherosclerosis. So atherosclerosis gets boosted when there is chronic inflammation. That's the nature of atherosclerotic plaques. They have inflammation in them. They have the foamy macrophages, which are nothing but immune cells. So the more the inflammation, the more they get encouraged to start to participate in the inflammatory breakdown, or rather inflammatory process of atherosclerotic plaque generation. So coronary artery disease is common and is the most common cause of death in patients of rheumatoid arthritis. Valvular involvement can occur, MS or MR can occur, even AR can occur. So mitral stenosis, mitral regurgitation, or aortic regurgitation, both valve and root dilatation, aortic root dilatation. The aorta can get dilated. Aortitis, vasculitis, as part of the vasculitis, though aorta is a large vessel, it can get involved. Root dilatation can occur. Okay. In rheumatoid arthritis, conduction defects can occur because of the conducting pathway getting affected. Okay, so these are certain additional manifestations. Just few things you remember, that should be enough. Although I may be elaborating a little more than what is necessary, please remember the points. Okay, neurological manifestations. Neuropathy is very common. Nerve entrapment in the form of carpal or tarsal tunnel syndromes. Rarely quadriplegia with phrenic nerve involvement in atlantoaxial joint subluxation. Peripheral neuropathies can occur. Okay. These are the neurological extra-articular manifestations. Ophthalmological, episcleritis can occur. So the difference between episcleritis and episcleritis, they'll have intense hyperemia, conjunctival suffusion, but they'll not have much pain. Whereas scleritis, they'll have a lot more pain. Okay, so that is one major difference between scleritis and episcleritis. And then scleromalacia perforans like this, okay, can occur if it's caused erosions within the sclera itself. And then secondary Sjogren's can occur, leading to Sicca complex, salivary gland involvement. These could occur, not very common, but could occur. Glaucoma could also rarely occur. Glaucoma, you suspect much more because of steroid use than rheumatoid arthritis, but possible manifestation. Okay, osteoporosis, spillover of the inflammation involving. See, this is periarticular osteoporosis is anyway going to be there, because the inflammation is right adjacent to the bones. But even the bones which are not adjacent to the joint, diseased joint, the distant bones can also undergo osteoporosis. So it's an important point because osteoporosis will lead to pathological fractures. Okay, so this kind of an erosive. So when you do an X-ray, especially X-ray hand, we don't do it very commonly now. But earlier, when we used to do X-ray hand to try and catch osteoarthritis, you could make out the erosions of the articular surfaces. So erosive arthritis you could document. Okay, Feltis syndrome. For you guys, just remember this triad. It should be enough. rheumatoid arthritis, splenomegaly, and neutropenia. Okay. Uh, it's basically the immune system going into overdrive. All the inflammatory cells rushing into the spleen. Spleen enlarges. The neutrophils start getting sequestered. They start going out of the blood vessels. Their lifespan also comes down because they're being activated so much. And then the rheumatoid factor will be high in these patients because of immune activation. Too much of IgM being produced against one's own IgG. So more common in more severe disease, more common in advanced rheumatoid arthritis. That means advanced disease also and long-standing disease also. So may those who have had towards the later stages of the disease, who have had rheumatoid arthritis for a long period of time, towards the later stages of the disease, they can develop Felty syndrome. Unfortunately, this can progress into developing into a malignancy also, into a lymphoma also. So lymphoma risk is also there. Felty syndrome. Yeah. I don't think you need to know too much about Felty syndrome. Just the triad you should remember. Um, yeah, same thing. Same thing, same thing, same thing. Yeah. Okay. Hematological manifestations. This is actually the most common one. So anemia of chronic disease is the most common extra-articular manifestation of rheumatoid arthritis if you don't count fatigue and constitutional symptoms. Okay, so those are more like symptoms. This is an objective sign or objective manifestation. Anemia. There is going to be anemia. Thrombocytosis. Any chronic inflammation, you can get thrombocytosis. Eosinophilia and leukocytosis may or may not be there. Not very common nor very important. Okay, so diagnosis is using the Euler ACR criteria, which Euler ACR has the following points: one regarding joint involvement, other involving serology, another involving acute phase reactants, and lastly, duration of symptoms. So as I said, if it's just one large joint involvement, it's very, very unusual, unlikely to be rheumatoid arthritis. So it gets 0 points, 0 score. Okay, if it is 2 to 10 involvement of large joints, 2 to 10 large joints, which are the large joints? Large joints are the shoulder, the elbow, the hip, the knee, the ankle. Okay, shoulder, uh, elbow, hip, knee, and ankle. I did not mention this. I'm sorry. The jaw can get involved in rheumatoid arthritis. Jaw uh, involvement or the mandibular surface getting involved, mandibular joint getting involved in rheumatoid arthritis can occur. Okay, we've seen patients with jaw involved in rheumatoid arthritis. Basically, many joints can get involved, including shoulder, but the only exceptions are DIP and the spine joints. These are not involved. Okay, so then 2 to 10 scores 1 point if it's only large joints. Then small joints, 1 to 3 scores 2 points, 4 to 10, 3 points, and more than 10 joints means 5 points. So basically, you need a score of 6. Okay. So if you have more than 10 small joints, 10 joints overall with at least one small joint being involved, then likelihood becomes very high for the diagnosis being rheumatoid arthritis based on this criteria, Euler ACR criteria. Okay. Euler is an abbreviation. Okay. Euler stands for European Union against League against rheumatism, something like that. Euler. I'm sorry, I don't remember the exact full form, but it's an acronym for the association, the European Association, then the American College of Rheumatology. So between the two rheumatological societies, they formed this criteria, which is currently recommended for making a diagnosis of rheumatoid arthritis. Serology, look at the rheumatoid factor and the anti-CCP. I told you anti-CCP is most specific. Rheumatoid factor is more indicative of severe disease. Anti-CCP also for that matter. So anybody who has a severe rheumatoid arthritis will have higher titer of anti-CCP also. Higher titer of RA factor also and anti-CCP also. So likewise, low positive is given 2 points, high positive is given 3 points. What do you mean low high positives? More than 3 times. Okay. More than 3 times of upper limit of normal. If it is higher than upper limit of normal, then it is considered high positive. So either of the two, if they are at least 3 times higher than the upper limit of normal according to the lab, the lab levels, lab limits, then they'll be considered as high positive or strongly high positive rheumatoid factor or anti-CCP. Acute phase reactant CRP and CRP and ESR being elevated. This is important because remember we were discussing about SLE being a differential. In a younger patient with non-erosive symmetric small joint arthritis, SLE is a differential. So in SLE, CRP will not be elevated. Okay. SLE, CRP is always normal. That's how you differentiate between SLE disease flare and a super added infection in SLE. Suppose a patient of SLE is having some manifestation. You're not sure. Is it an aggravation of SLE itself, or is it that he has developed an infection? So CRP will help you decide that. If the CRP is elevated, it's not because of SLE disease activity. It's because of bacterial infection. So likewise, if you're in doubt, SLE, rheumatoid, which one could it be? One of the factors that may help you is CRP. If the CRP is high, much more in favor of rheumatoid arthritis than SLE. Okay. Duration of symptoms, like I said, less than 6 weeks becomes very unlikely. That's why it's given 0 points. But more than 6 weeks gets you 1 point. And overall, when you calculate the score in a particular patient, particular individual, the score should be more than 6 out of 10. You can make a diagnosis of definite rheumatoid arthritis, definite diagnosis of rheumatoid arthritis. Otherwise, it becomes probable rheumatoid arthritis if it's not if it's not meeting the cutoff of 6 or more out of 10. Okay, so what are the investigations you want to do? You want to do inflammatory markers, including ESR that you need for diagnosis, CRP. You also want to look for acute phase reactants like CRP, like negative acute phase reactants like albumin also. And then thrombocytosis, you may notice it when you're doing the test, but it doesn't really help you make the diagnosis. What you really want to look for are rheumatoid factor and anti-CCP. Anti-CCP is the most specific autoantibody in rheumatoid arthritis. Okay, if you take X-rays, you will notice evidence of erosive arthritis with juxta-articular osteoporosis, okay, or periarticular osteoporosis, narrowing of joint space, erosion of the cartilage, all that will be visible. Ultrasound and MRI have a very good sensitivity. Therefore, if you're suspecting somebody with early disease, early rheumatoid arthritis, you may not catch anything on the X-ray. Best to send them for an MRI. MRI would be much more sensitive. Ultrasound also to an extent, but MRI very, very sensitive. Okay, and synovial fluid, we generally don't do this. So, but if there is significant amount of edema, significant joint swelling and edema, can do a joint synovial fluid analysis, and then theoretically you can do arthroscopy and all. Okay, but mainly our diagnosis relies on clinical, because joint involvement you have to see and duration you have to see. And in addition to that, the anti-CCP, rheumatoid factor, ESR, and CRP. These are the 4 things from the lab side and the clinical signs and history, which is important to making a diagnosis of rheumatoid arthritis. Okay. Management. Now, for patients with the very severe joint pain, they require analgesics for adequate relief of their pain. So NSAIDs are the first line. So a lot of times, patients of rheumatoid arthritis may end up developing elevated creatinine levels. So what are the factors for that? Analgesic overuse, frequent NSAID use, or patient may end up developing amyloidosis. So I told you secondary amyloidosis can occur in as a result of inflammation. Very rarely glomerulonephritis. Very, very rarely. The glomerulonephritis in rheumatoid arthritis is generally membranous nephropathy. Okay, membranous nephropathy, glomerulonephritis that's rare in rheumatoid arthritis. So you need to watch out. If they're on analgesics, you educate them that analgesic nephropathy is a real risk. Don't use it unless it's really, really necessary. Okay. So you give them NSAIDs. uh, the thing is, NSAIDs are not the long-term solution. Neither are steroids. So you can give them low-dose steroids also. So either give them steroids or non-steroidal anti-inflammatory agents. So you can give them corticosteroids at low dose for short term. So short term low dose corticosteroid therapy you can give to reduce the inflammation. But after all, this is an inflammatory disorder. So you can give it for short term, overlap with DMARDs, because DMARDs take some time to act. So till the time that DMARD actions have begun, you can sort of overlap with the analgesics, including analgesics like NSAIDs or steroids. And then there are disease-modifying anti-rheumatic drugs. Which are they? There are the conventional DMARDs and the biologicals. So this is totally out of use. Gold, orphan, or enophine, totally out of use. We don't use that. Not used it for a long time. Not used. Depenicillamine not used. Sulfasalazine, it's there, but uncommonly used. Hydroxychloroquine definitely used, but not very effective. So hydroxychloroquine, it's not by itself as an isolated drug. It's not a great DMARD. Okay, very, very low efficacy. Low efficacy. So it's not a true DMARD. It doesn't really modify the disease progression. But when given with other drugs, it can help. It can actually help maintain a lower dosing of other drugs by adding on to their effects. So methotrexate, yes, most commonly used. We know it works well. Okay, if you keep giving methotrexate for like 2 years, we see very good relapse. Very good remission of patients with rheumatoid arthritis who are maintained on methotrexate for long periods. Okay, leflunomide sometimes we use 20 mg leflunomide. Yeah, so combination of DMARDs are always preferred, especially with analgesics, because of overlap. Time taken is generally 6 weeks, but it can even extend up to 3 to 4 months. So at least 2 months for sure, but then it could extend even 3 to 4 months also. So you have to educate the patients that what you're starting, if you're starting methotrexate, it's not going to act in a week or two. It's going to take some time. Till that time, you have to continue analgesics or steroids. Okay, so don't expect immediate relief. Yeah, so methotrexate is the drug of choice among the conventional DMARDs. So it's a conventional DMARD. And DMARDs, they say DMARDs. Okay, it's weekly once, dosing is weekly once, and you cover with the folic acid just to prevent the bone marrow toxicity, as well as the other toxicities of associated with the methotrexate. So it's a very good, very efficacious drug. Watch out for side effects. You need to monitor. Need to monitor. Need to monitor LFTs, CBCs, CBC, LFT, and creatinine, RFT. I'll put it as renal function test, liver function test, CBC. You need to monitor. Though it can affect the lung, but PFT we generally don't. Maybe once annual PFT you can do. Annual PFT. Okay, not very routinely done, but maybe it makes good sense to just keep an eye on the pulmonary function test. But LFT, CBC, and creatinine values are routinely tested because it can cause nephrotoxicity. It can crystallize because methotrexate can crystallize in the tubules, can produce renal damage. CBC, bone marrow suppression, leukopenia, thrombocytopenia, all these can occur. LFT derangement can lead to liver fibrosis also. So need to keep an eye on these. Methotrexate, most commonly used, weekly dosing, conventional DMARD. Other DMARDs, okay, these are just out of question only. So no depenicillamine, no gold. Okay, sulfasalazine, okay, maybe used sometimes. Leflunomide also sometimes used. You can remember the names, but not very frequently. Sometimes we add on leflunomide. So to to methotrexate. If they're not adequately controlled and they're not willing for biologicals, then you can add on, apart from methotrexate and HCQS, you can add on leflunomide like that. Okay. Then we have biologicals. So biologicals will act at a particular step in the inflammation, and these include TNF alpha inhibitors. TNF alpha is definitely involved in the pathogenesis of rheumatoid arthritis, and therefore anti-TNF alpha inhibitors. I've told you already what is the mnemonic? ISAGE. Okay, that is infliximab, certolizumab, adalimumab, golimumab, etanercept. Okay, so etanercept is actually not a monoclonal antibody. It's it's a receptor, TNF alpha receptor fusion protein. So yeah, so here it is. Soluble receptor fusion protein, that is etanercept. This can be used. So these are against certain cytokines like TNF alpha. Likewise, tocilizumab is against a cytokine, that is interleukin 6. Okay, anakinra is against interleukin 1. So anti-cytokine agents can be biologicals, or anti-T cell or anti-B cell. Anti-B cell is anti-CD20, that is rituximab. Anti-T cell is abatacept, which is against the CTLA4 receptor. So you can use DMARDs in the management of rheumatoid arthritis, generally reserved as second line. Try with methotrexate, not working, then offer biologicals. They're not without their side effects and are expensive. Infliximab, chimeric IgG1 monoclonal antibody that binds to TNF alpha and TNF13 also, but TNF alpha mainly. Initially, we give a dose which you should give between 2 to 6 weeks, and then after that, we increase the duration between the doses, 8 weeks. Reactivation of tuberculosis. I guess you don't need to know too much about each individual drug. Infliximab, etanercept, adalimumab. These are the same drugs which are used in IBD, right? IBD and RA drugs are quite similar, except etanercept. Etanercept is not used for IBD, not for IBD. It's not approved for IBD. It's approved for rheumatoid arthritis only. Etanercept, not for IBD. Okay, and then immunosuppressive agents, you can add on azathioprine. Very rarely we use. That's the problem. Azathioprine can also produce ILD. So very tricky. Cyclophosphamide again can produce ILD. It's used for treatment of ILD actually, but then it can have its reactions in the lung also. Okay, cyclophosphamide may be useful for acute vasculitis. So, and what is the role of steroids? Don't give them long-term steroids. Use low-dose steroids for short-term treatment to provide an overlap or a cover for the time that the DMARDs take. So you initiate the steroid only aiming to continue till they have symptomatic benefit due to DMARDs. Because symptomatic benefit due to DMARDs takes at least 6 to 8 weeks. You need to bridge that gap. You can use NSAIDs or you can use steroids. Okay. Yeah. Otherwise, finally, surgical therapy, if there are too many deformities, advanced disease, untreated, did not receive DMARDs, continue to progress, and now has developed disabling deformities, they need to be corrected surgically. Okay. Uh, life-threatening manifestations like the atlantoaxial joint subluxation, such patients also will require surgery. Compressive myelopathy that needs to be decompressed. Okay, so with that, I think we'll conclude today's discussion on rheumatoid arthritis. Any doubts? So it's a systemic inflammatory disorder. It's a joint disorder, no doubt. Joint inflammation is the most typical manifestation, but there are extra-articular manifestations also, all thanks to the inflammation that is incited by certain changes in composition of peptides. Most often the peptide is in the joint, sometimes outside. And number of clinical features, number of differentials you should keep in mind, like SLE, psoriatic arthritis, osteoarthritis, and diagnosis. And the DMARDs, DMARDs classified into conventional and biologicals. So conventional DMARDs, please remember, methotrexate, HCQS. These two we start for almost all patients of rheumatoid arthritis. So conventional DMARDs, DMARDs. That's easier to say also. DMARDs. Okay, methotrexate, HCQS, leflunomide, and sulfasalazine. These are the four more often used conventional DMARDs. Gold, penicillamine D, and all way out of use, outdated. And then there are biologicals. Biologicals could be against cells, anti-B cell, anti-T cell, abatacept, or rituximab, or it could be against cytokines like TNF alpha, or interleukin 6, or interleukin 1. Anakinra against interleukin 1, tocilizumab against. Asking question in the YouTube section. Oh, I'm sorry. What is the question in the YouTube section? I'm not switched on the YouTube. Hold on. Where is the YouTube link? Hold on. Yes, hold on. What is the question? Where is the YouTube link? Comment. Okay, I'm sorry. Silicosis. Okay, anti-CCP. Churg-Strauss. Churg-Strauss was the answer for how to remember deformity of rheumatoid arthritis. There's not much, no? Silicosis. Okay, anti-CCP. How to remember, Rajesh has asked how to remember the deformities of rheumatoid arthritis. There's not much. If you think about it, the upper limb, what do we have? Upper limb, we have mainly the finger deformities. That is, we have swan neck. Swan neck is easy because there's flexion at the distal interphalangeal joint and hyperextension at the proximal interphalangeal joint. Distal interphalangeal joint, there's flexion. Proximal, there is hyperextension. So that is swan neck deformity. Swan neck. Then that is in the finger. Then there's Boutonniere's deformity. Boutonniere's deformity, that is buttonhole. Buttonhole meaning there is going to be hyperextension at the DIP. There's flexion at the PIP. Okay. These two you have to remember. It's not very, at least it's quite obvious, no? Swan neck like this. I feel it's okay. You can remember those. Z deformity, you can remember, usually affects the thumb. Thumb becomes Z shaped, Z deformity. And ulnar deviation is very, very common. You should see patients of rheumatoid arthritis very frequently. You'll see ulnar deviation. Okay, so ulnar deviation is not at all uncommon. You'll see it. Swan neck also not very uncommon. Boutonniere is a little uncommon. Z deformity also in like very elderly patients who initially did not receive DMARDs, now they'll have Z deformity. Otherwise, that is also not very common. So ulnar deviation is another deformity. Just the major ones you can remember. Okay, spindling of the digits. Then what about the lower limb? Lower limb windswept deformity. Windswept. So basically, there's going to be lateral deviation of the digits. Okay, so windswept deformity. There can be hammer toe, and then there can be there can be bunion that you can see. Okay, just a few you can remember. You need not have to remember all of them. These are also in the foot, also not very common these days. So these five, six, at least you can remember easily. I hope it's not too difficult. I don't have a mnemonic for it, but because I felt this is okay, it's not so difficult to remember. There's no other joint where it's going to produce typical deformities. Vishal's asking about the notes. Okay, it's there. I've shared the slides with the group, the White Army group, WhatsApp group. So maybe I'll tell. Um, I'll just see if I can uh, inform Kishan sir if he can share the notes, share or you give you access to the group. Okay. Any other questions? Anti-CCP. Church Strauss was asked. Church Strauss for what? Church Strauss is GPA, granulomatosis with polyangiitis. When do you think of granulomatosis with polyangiitis? It's a patient with asthma who's not responding to treatment, conventional treatment. So asthma patient not improving. If they have peripheral eosinophilia, they must also have eosinophils in their lungs. Eosinophilic, I'm sorry, I wrote it as GPA. I'm so sorry. EGPA. So eosinophilic granulomatosis with polyangiitis. Okay, so asthma patient not responding. They have peripheral eosinophilia. They'll have eosinophilic granulomas within their lungs also. And very often they'll have nerve involvement. They'll also have cardiac involvement. Um, they'll have manifestations in very rarely in the kidneys, mainly nerves, cardiac, palpable purpura may be seen EGPA.